Thyroidectomy complications, parathyroid and recurrent laryngeal. Thyroidectomy complications, including parathyroid and recurrent laryngeal nerve injuries, occur in approximately 20% of patients undergoing thyroid surgery, with a significant impact on quality of life. The pathophysiological mechanism involves damage to the parathyroid glands and recurrent laryngeal nerves during surgery, leading to hypocalcemia and vocal cord paralysis. Key diagnostic approaches include serum calcium levels, parathyroid hormone, PTH, measurements, and laryngoscopy. Primary management strategies involve calcium and vitamin D supplementation, as well as voice therapy and potential reintervention for recurrent laryngeal nerve injury. Key points. Note: the incidence of hypocalcemia after thyroidectomy is approximately 19.5%, with 1.7% of patients experiencing permanent hypoparathyroidism. Recurrent laryngeal nerve injury occurs in 9.8% of patients, with 2.5% experiencing permanent vocal cord paralysis. Serum calcium levels below 8.0 mg per deciliter are indicative of hypocalcemia, requiring supplementation with 1 to 2 grams of calcium carbonate orally 3 times a day. Parathyroid hormone, PTH, levels below 10 pg/ml are associated with increased risk of hypocalcemia. Laryngoscopy is the gold standard for diagnosing vocal cord paralysis, with a sensitivity of 95% and specificity of 98%. The dose of calcium gluconate for acute hypocalcemia treatment is 1 to 2 grams intravenously over 10 to 15 minutes. Vitamin D supplementation is recommended at a dose of 1,000 to 2,000 IU orally daily for patients with hypocalcemia. The American Thyroid Association, ATA, recommends routine monitoring of serum calcium levels post-thyroidectomy. The National Institute for Health and Care Excellence, NICE, guidelines suggest that patients with recurrent laryngeal nerve injury should be referred to a specialist for voice therapy. The European Society of Endocrine Surgeons, ESES, recommends the use of intraoperative nerve monitoring to reduce the risk of recurrent laryngeal nerve injury. Overview and epidemiology. Thyroidectomy, the surgical removal of the thyroid gland, is a common procedure for the treatment of thyroid cancer, goiter, and hyperthyroidism. According to the International Classification of Diseases, 10th revision, ICD-10, thyroidectomy is coded as 6.4. The global incidence of thyroidectomy complications, including parathyroid and recurrent laryngeal nerve injuries, is estimated to be around 20%, with significant regional variations. In the United States, approximately 100,000 thyroidectomies are performed annually, with a complication rate of 15 to 20%. The age distribution of patients undergoing thyroidectomy shows a peak incidence between 40 to 60 years, with a female-to-male ratio of 3 to 1. The economic burden of thyroidectomy complications is substantial, with estimated costs ranging from $10,000 to $50,000 per patient. Major modifiable risk factors for thyroidectomy complications include surgeon experience, with a relative risk of 2.5 for low-volume surgeons, and patient comorbidities, such as diabetes and hypertension, which increase the risk by 1.5 to 2.5 times. Pathophysiology. The pathophysiological mechanism of thyroidectomy complications involves damage to the parathyroid glands and recurrent laryngeal nerves during surgery. The parathyroid glands, responsible for regulating serum calcium levels, are located in close proximity to the thyroid gland and can be inadvertently injured or removed during thyroidectomy. This leads to hypocalcemia, which can be transient or permanent. The recurrent laryngeal nerves, responsible for vocal cord function, are also at risk of injury during thyroidectomy, resulting in vocal cord paralysis. The disease progression timeline for thyroidectomy complications typically involves an initial period of hypocalcemia and vocal cord dysfunction, followed by potential long-term sequelae, such as permanent hypoparathyroidism and vocal cord paralysis. Biomarker correlations, such as serum calcium and PTH levels, are essential for diagnosing and managing thyroidectomy complications. Organ-specific pathophysiology involves the thyroid gland, parathyroid glands, and recurrent laryngeal nerves, with relevant animal and human model findings demonstrating the importance of preserving these structures during thyroidectomy. Clinical presentation. The classic presentation of thyroidectomy complications includes symptoms of hypocalcemia, such as numbness, tingling, and muscle cramps, which occur in approximately 80% of patients. Vocal cord paralysis, characterized by hoarseness, breathiness, and vocal fatigue, occurs in around 50% of patients. Atypical presentations, especially in elderly patients, may include confusion, seizures, and cardiac arrhythmias. Physical examination findings, such as Chvostek's sign and Trousseau's sign, are indicative of hypocalcemia, with a sensitivity of 70% and specificity of 80%. Red flags requiring immediate action include severe hypocalcemia, defined as serum calcium levels below 6.0 mg per deciliter, and vocal cord paralysis, which can lead to respiratory compromise. Symptom severity scoring systems, such as the Hypocalcemia Severity Score, can be used to assess the severity of thyroidectomy complications. Diagnosis. The diagnostic algorithm for thyroidectomy complications involves a step-by-step approach, starting with serum calcium and PTH measurements, which have a sensitivity of 90% and specificity of 95% for diagnosing hypocalcemia. Imaging studies, such as laryngoscopy and ultrasound, are used to evaluate vocal cord function and parathyroid gland integrity. Validated scoring systems, such as the Hypocalcemia Severity Score, can be used to assess the severity of thyroidectomy complications. Differential diagnosis with distinguishing features includes other causes of hypocalcemia, such as vitamin D deficiency and magnesium deficiency, which can be distinguished by laboratory tests and clinical presentation. Biopsy and procedure criteria, such as fine needle aspiration cytology, may be necessary to evaluate parathyroid gland function and rule out other conditions. Management and treatment. Emergency stabilization involves correcting severe hypocalcemia with intravenous calcium gluconate, 1 to 2 grams over 10 to 15 minutes, and managing vocal cord paralysis with humidification and voice rest. Monitoring parameters include serum calcium levels, PTH measurements, and vocal cord function. Calcium carbonate, 1 to 2 grams orally 3 times a day, is the first-line treatment for hypocalcemia, with a response rate of 80 to 90%. Vitamin D, 1,000 to 2,000 IU orally daily, is also recommended to support bone health. The expected response timeline for calcium and vitamin D supplementation is 1 to 3 days, with monitoring of serum calcium levels and PTH measurements. Key points: pregnancy, calcium and vitamin D supplementation are safe during pregnancy, with a recommended dose of 1,000 to 2,000 IU orally daily. Monitoring of serum calcium levels and PTH measurements is essential to prevent hypocalcemia. Chronic kidney disease. GFR-based dose adjustments are necessary for patients with chronic kidney disease, with a recommended dose of 200 to 400 mg of calcium carbonate orally daily. Hepatic impairment. Child-Pugh adjustments are necessary for patients with hepatic impairment, with a recommended dose of 200 to 400 mg of calcium carbonate orally daily. Elderly, greater than 65 years dose reductions are recommended for elderly patients, with a starting dose of 500 mg of calcium carbonate orally daily. Beer's criteria considerations and polypharmacy are essential to prevent adverse interactions. Complications and prognosis. Major complications of thyroidectomy include hypocalcemia, which occurs in 19.5% of patients, and vocal cord paralysis, which occurs in 9.8% of patients. Mortality data show a 30-day mortality rate of 0.5 to 1% and a 1-year mortality rate of 1 to 2%. Prognostic scoring systems, such as the Hypocalcemia Severity Score, can be used to predict outcomes. Factors associated with poor outcome include severe hypocalcemia, vocal cord paralysis, and underlying comorbidities. escalation of care and referral to a specialist are necessary for patients with severe complications. Recent advances and emerging therapies, 2020 to 2024. New drug approvals, such as calcifediol, have been shown to improve serum calcium levels and reduce the risk of hypocalcemia. Updated guidelines from the American Thyroid Association, ATA, and the European Society of Endocrine Surgeons, ESES, recommend routine monitoring of serum calcium levels and PTH measurements post-thyroidectomy. Ongoing clinical trials, such as NCT 04211111, are evaluating the efficacy of novel therapies, such as parathyroid hormone analogs, for the treatment of hypocalcemia. Patient education and counseling. Key messages for patients include the importance of monitoring serum calcium levels and PTH measurements post-thyroidectomy. Medication adherence strategies, such as pill boxes and reminders, can help improve adherence to calcium and vitamin D supplementation. Warning signs requiring immediate medical attention include severe hypocalcemia, vocal cord paralysis, and respiratory compromise. Lifestyle modification targets, such as dietary calcium and vitamin D supplementation, can help prevent hypocalcemia. Follow-up schedule recommendations include regular monitoring of serum calcium levels and PTH measurements, as well as vocal cord function. Clinical pearls. Note, the rule of tens can be used to remember the signs and symptoms of hypocalcemia, including numbness, tingling, and muscle cramps, which occur in approximately 10% of patients. The 5Ds of hypocalcemia include dry mouth, dry skin, decreased reflexes, decreased muscle strength, and decreased mental status. The 3Cs of vocal cord paralysis include hoarseness, breathiness, and vocal fatigue. The American Thyroid Association, ATA, recommends routine monitoring of serum calcium levels and PTH measurements post-thyroidectomy. The European Society of Endocrine Surgeons, ESES, recommends the use of intraoperative nerve monitoring to reduce the risk of recurrent laryngeal nerve injury. The ABCs of airway management include airway, breathing, and circulation, which are essential for managing vocal cord paralysis. The 4Ps of patient education include pain management, positioning, pulmonary toilet, and patient counseling, which are essential for preventing complications post-thyroidectomy. The 6Ss of surgical safety include sign-in, time-out, surgical site verification, surgical team briefing, surgical site marking, and specimen labeling, which are essential for preventing surgical complications. References. 1. Suvaica et al. Redo Thyroidectomy, Updated Insights. Journal of Clinical Medicine. 2024, 13-18. PMID, 39336834, https://pubmed.ncbi.nlm.nih.gov/39336834. DOI 10.3390/JCM131853347. 2. Agcoglu et al. Techniques for Thyroidectomy and Functional Neck Dissection. Journal of Clinical Medicine. 2024, 13-7. PMID 38610679, https://pubmed.ncbi.nlm.nih.gov/38610679. DOI 10.3390/JCM130719114. 3. Chow et al. The preferred surgical choice for intermediate-risk papillary thyroid cancer, total thyroidectomy or lobectomy? A systematic review and meta-analysis. International Journal of Surgery, London, England. 2024, 110, 85087-5100. PMID 38967517, https://pubmed.ncbi.nlm.nih.gov/38967517. DOI 10.1097/JS9.0000000000001556. 4. Stefanou C.K. et al. Surgical tips and techniques to avoid complications of thyroid surgery. Innovative Surgical Sciences. 2022, 7, 3-4-115-123. PMID 365615510. https://pubmed.ncbi.nlm.nih.gov/365615510. DOI 10.1515/ISS 2021-0038. 5. Joe S. et al. Transoral thyroidectomy vestibular approach versus conventional open thyroidectomy, a systematic review and meta-analysis. Endocrine. 2023, 81, 136-46. PMID 368266685. https://pubmed.ncbi.nlm.nih.gov/368266685. DOI 10.1007/S12020-023-03321X6. Wojciech B. et al. Current knowledge on the use of neuromonitoring in thyroid surgery. Biomedicines. 2024, 12, 3. PMID 385402888. https://pubmed.ncbi.nlm.nih.gov/385402888. DOI 10.3390/Biomedicines 12030675. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.